communities. That especially in rural communities and low-income communities, the need is still great. And especially right now, I would tell you that with our number one pain point being workforce, it continues to be a real issue for all of us. Community health centers are rooted in the belief that healthcare is a human right and that comprehensive care services should be available to all, regardless of the ability to pay, regardless of insurance status or immigration status. And I think one of the things that sets us apart too is that from the very beginning, we believed in comprehensive services. So I know for La Clinica, from the very beginning, we pretty much offered dental, behavioral health, optometry, and health education. And so I think that sets us apart, and it makes those core services a very important part of this of what we provide our communities. Um, we believe that community health centers are mission driven to deliver care with respect and dignity. And I will tell you that many times our patients still walk into our clinics and they're uninsured, and we have been able to find many programs that they qualify for. So a big part of what we do is help connect people to whether it's Medi-Cal, and especially right now, we're very, very proud and excited that in January, the last segment of undocumented immigrants will now be eligible for Medi-Cal. We're so proud of that because that has been a part of our mission from the very beginning. And most of us are now looking at 50 plus years. So we've been fighting for access for all since the very, very beginning. And to have a sense that we're going to realize that in January is a big feather in our cap. And it's something we're very proud of and very excited about for our communities. But it's not unusual for a family, for an individual patient to walk in and not know that they're eligible for Medi-Cal, especially right now post COVID. Um, but what we do is help people go through the process, help them complete the paperwork, which is onerous, and also a big part of what we do is allay any fears that they may have about whether applying for Medi-Cal is going to in any way affect their immigration status. So I think one of the things that sets us apart is that we are trusted by our community. And when we're able to reassure our patients that they're going to be fine applying for Medi-Cal, that means a lot. And we have found that to be a very meaningful part of the work that we do. Um, we are rooted in trying to help reduce the healthcare disparities and improve health outcomes for minority, immigrant, and refugee communities. And this belief in providing equitable healthcare to all still exists today as a core part of our mission statements. So today, community health centers have grown significantly since the inception. I remember when we first started CPCA, our state association, there were 32 what would now be called federally qualified health centers, 32. And then today, we're over 600 of us. And so there has been tremendous growth. And heaven knows that we needed that kind of expansion in our services. So it's really good to see. We're serving millions of patients across the county, across the state. Here in Alameda County, we are actually the system of care. So the county itself does not have that many community health centers, and they trust us, they invest in us, and we are their system of care. I think that one in every third Medi-Cal patient is a patient of a community health center. And from where we came, that's an amazing, amazing number. And I think where we've grown is not only, in health centers in our communities, but we are also a big part of school-based health centers. I know La Clinica has something like 12 school-based health centers. We have mobile clinics. And we've been able to get around, and this really helps us to meet our patients where they are. From the very beginning, we were really promoting not only community health, but prevention and health equity. And one of the big parts of our core services and our mission is the social determinants of health. And when I was in graduate school 40 years ago, 42 years ago, I remember hearing about the social determinants of health, and it made so much sense, right? But when I actually got into the system, it wasn't like it is now, where it's a key part of what we're doing. And so it's really gratifying to see that now we are more capable and able to provide housing advice, food insecurity services, economic stability. And so the social determinants are very much girding our philosophy and our mission. And that's a very important part of the work. And I like to remind us that, if we're lucky, we have a half an hour with a patient and a family. And what happens to that patient and that family outside of that half hour has more impact on their health status than what we can normally do with a family and a patient. So those social determinants of health are very important, and it's really gratifying now as we see some changes in the delivery system that they are a key part of how we're providing value-based care and how we're changing that. We are part of a program called Food is Medicine, where we're able to prescribe food and issue often recipes. We're really excited to do that work, where the recipes meet, they look like the food that we're distributing, and they're culturally responsive to the communities that we're serving. So it's a lot of fun. It's really been great to see, and our staff are really excited about doing that. So, for our area here, collectively, the health centers are serving about 285,000 patients. 88% of those are Medi-Cal or uninsured, but 83% identify as people of color. So as you can see, we are serving a very, very critical need, and I think we're very definitely making a difference in the delivery system and in outcomes. Um, I think there's a reliance now on community health centers to provide affordable healthcare services. And again, I think one of the things that I'm very proud of is the fact that we're, we are key to the delivery of dental services. I think if it weren't for community health centers, the availability of affordable dental care services to our communities would be almost non-existent. So I think that's a really important part of the work that we do. And then, of course, the other area is behavioral health. And it's very gratifying to see now behavioral health post-COVID. Uh, we're starting to see that the stigma that used to associate accessing behavioral health services we're driving it away, and we're making it okay, and to receive mental health services in our school-based health centers. It's funny because we originally started very much with the medical model, and quickly we had to reinvent ourselves to add behavioral health services because that's what our youth were presenting with. So I think that's a really important part of the work that we're doing. Um, I think one of the biggest parts that I want to focus in on today is the critical role that we played during COVID. And I will tell you that in Alameda County, for example, that we were quickly able to pivot to telehealth. And in our county, the Alameda County deputized us, so we were able to do tracing in addition to vaccinations and testing. And that really turned out to be quite important to our patients, especially our immigrant patients, um, because they trusted us. And when we called them, we knew they would answer our call, and the counties were not so sure that that would be the same with them. So I think it was a real important part of the work that we did. Community health workers are a very important part of the work and the outreach that we do, and they live in the
Mm,
community, they work with the community. I guess I'm running out of time here. I did just want to share that our commitment also is in the boardroom. So all of us have more than half of our board members are consumers. And, we did that way before HRSA required us to do that because we believed that the community needed to have ownership of the clinics. And I think that has served us well. The role we played in COVID was incredibly important in our community. 34% of our community was testing positive. And we were so creative. I think one of the things I'm really proud of is that we actually converted our dental staff, and they were the ones doing testing and tracing and all that work. So it was really, really important. I think just in closing, I would say that a lot of the changes that we're seeing in value-based care, in population health management, in the affordable in APM, it's playing to our strengths. So I think we're in a really good position to do the work that we're very comfortable with. This has been our advocacy work at play that's allowing us to make these changes. So very proud to be part of the movement. Thank you for giving me this time, and si se puede.
Thank you, Jane. That was an amazing history that you were able to share with us and bring us forward. And thank you to all of the amazing work and the impact that you and your team, as well as other members of the Community Health Center movement, have made to transform lives. This is what we're here to do, and wanted to honor that. I will be doing just one brief housekeeping comment. We have about 100 people who are joining us today. So if you are joining recently, please make sure you're dropping your name and organizational affiliation in the chat. And then I will be turning the call over to Max Perret, Director of Policy and External Affairs with Aliados Health. Max?
Thank you so much, and great to see so many friends on here. Thank you for joining, and to everyone for your commitment to the Community Health Center movement. We've got folks on today from the federal level and our federal partners, the state and our state partners in the state legislature, and governor's office, and we've got local partners as well in our cities and our counties. So thank you so much. Up on the screen is all of our member health centers across the region. This takes all of us, and we just have so many incredible community health centers. Some are federally qualified health centers, others are free clinics or Indian health centers. So just wanted to acknowledge all of our mental and primary care physicians, nurses, and providers across the region. Can we go to the next slide? Our combined impact, if we look across the Bay Area region, in addition to Yolo County, we have 849,000 total patients in terms of encounters each year. If you look at the different service breakdown, you can see 101,000 mental health visits, 99,000 enabling services, 34,000 vision, dentals at 151,000, and of course, medical tops out at 686,000 across the region. If we look at our patient population, right, we're looking at 82% under 200% of the federal poverty level, with 63% on Medi-Cal. Medi-Cal is 138% of the poverty level and below. And we also have that 19% that remains uninsured. And as Jane Garcia referenced, right, with Health for All, which was a big advocacy push, which many of you were a part of, we'll be seeing undocumented immigrants in that last age gap be eligible for Medi-Cal come January 1st of next year. So that uninsured population is expected to go down partially. Our total workforce across the region, 6,000, but above 6,000 workers. So we're also a big part of the local economy in many of our counties as well. And with that, I'll turn it over to Tony.
Thank you, Max. And now we're going to be turning the call over to our next presenter, Asa. Asa, the deck is yours.
So if we can go to the next slide. So my name is Asa Satriano. I'm the CEO at South of Market Health Center. here in San Francisco, California. And a little bit about who South of Market is. We have been, this is actually our 50th year. We're celebrating our 50th year gala tomorrow, actually. And we serve about 71% of our about 4,500 patients are at or below the federal poverty level. That means for a family of 3, they're making less than $23,000 a year. 90% of our patients, similar to what Max was saying, are below that 200% of poverty level, which equates to $46,000 a year. And in San Francisco, which is one of the most expensive places to live, that's not a lot of money. It's very difficult to live on that. So you can imagine having to decide whether I get healthcare or whether I feed my family puts the community health centers in a perfect space to care for this very vulnerable population. 15% of our patients are homeless, 81% are racial or ethnic minorities, as defined by HRSA, and 21% are best served in a language other than English. Now, this is South of Market specific, but it mimics what you see across the state. Next slide, please, Tony. And what makes a community health center unique, regardless of where the funding source comes from, when you're looking at a community health center, you're looking for someone that is not just based on business, how the dollars and cents of healthcare, but rather making sure that we're serving the community. So our boards are required, but as Jane mentioned, our boards have always been comprised of our patients. More than half of our 51% of our board has to be users or patients of our clinic sites. So therefore, we're hearing firsthand every month, sometimes even more than monthly, what's going on in the clinic, from a level that we wouldn't normally see. But that informs us and keeps us honest and keeps us grounded and allows us to provide what the community needs and not just what we think as a business we want to do. All federally qualified health centers are required to offer a very comprehensive range of services. Many of these services are required. Some of us are able to do them on site. Many of us contract or collaborate with our county hospitals or other, community business organizations in the area. And that includes primary medical care, laboratory, radiology, screenings, family planning services, well child services, gynecology care, preventative dental. There's a very long list of services. And at South of Market, we do provide most of those. We have medical, dental, behavioral health, and we also do podiatry, and we just recently started acupuncture and pharmacy. We're looking to move into the food pharmacy space, similar to Jane mentioning. Many of our colleagues have it. We're just a little landlocked, and so we're trying to find the room for that. We help patients navigate the very complex web of insurance options. People walk through the door, they don't know what they qualify for. They don't know how they're going to pay for this visit, but we're able to make that affordable and attainable and accessible for them. So whether that's in San Francisco, we have Healthy San Francisco, or we're offering, making sure that they are signing up for Medi-Cal, or we're just adding them to our sliding fee discount program so that we can, give them a more reasonable rate for the care that they're seeking. We make healthcare available and accessible, and that is what community health is about. And we also do a lot, and actually this slide I realized was written just a little bit wrong. Integration is far beyond just behavioral and primary care. We are actually looking at total health and total care. So integration happens across all of the sectors: behavioral health, primary care, and dental. And I know right now there's a big push to figure out how to sort of finish the loop on integrating behavioral health directly to dental, but through primary care, all three services are always connected. And those integrations look like warm handoffs. It's having all of the staff on site or very close by, so that when a patient is in the primary care office seeing their doctor for their high blood pressure and they're recognizing that that may be caused by anxiety, having a behavioral health provider walk into the room and start that handoff of hey, let's have some conversations and see how we can help you with your anxiety. So it's just a quick example of how integrated care works. And we do that at not just at South of Market, but at all of the clinics across the country. Next slide, please. 22% of our patients are pediatric. We offer those services at 2 of our locations, and we do full service. So, you know, their medical, their behavioral health needs, their dental needs. We want to serve the whole patient. And I know sometimes people look at our funding and they think that we get paid these crazy amounts of money, but we don't. We get paid an appropriate amount of money based on the fact that we do a lot of wraparound services that are not we don't get compensated for those services. So if you can imagine, the patient comes in to see the doctor, and yes, we got paid for that, but I have community health workers, and I have nutritionists, and I have other people that aren't recognized as part of they're important to the care, but they're not recognized as compensatable. So we provide those services knowing that actually, you know, benefits the whole person. So our funding, yes, may look like we get a lot of money, but we really don't, because we're offering so much more. 17% of our patients are seniors, and I won't read these in complete totality, but they're there for your information. And I think I have one more slide. And what makes us different? Excuse me. We are looking for people to come in and be cared for, and not necessarily what type of insurance card they hold in their hand. You know, whether you have insurance, don't have insurance, are underinsured, we want to care for you. So often, you know, when people call and they say, do you take our insurance? I might, but I'd rather you come in and let's make sure you're stable. That's a big difference from the for-profits and from some of our other colleagues who, you know, if you don't have that right card, you can't have service. At South of Market, like I mentioned, we have primary care, behavioral health, and other specialties, including genetic counseling and podiatry. We do partner with Zuckerberg San Francisco General, which is staffed by UCSF doctors, and we also partner with the other local hospitals. And we'll be looking to potentially have a partnership with Kaiser in the near future. And, you know, for us, it's about the health and curing, and really not just curing the disease, but making sure the person is taken care of. So their housing, their food, their transportation, their safety, all of that leads to being healthy and healthier. And that is what community health is about. Thank you. Tony, I'll turn it back to you.
Thank you, Asa. That was really an amazing way that you just brought to life exactly the uniqueness of the community health center model. Now we're going to turn the presentation to Louisa.
Good morning, everyone. I'm Louisa Boada, the CEO of Ravenswood Family Health Network here in East Palo Alto. And we are also located in the cities of Palo Alto, Mountain View, and Sunnyvale. And our service area covers northern Santa Clara County and southern San Mateo County. Like many of my colleagues before, we are federally qualified health center. 96% of our patients are people of color, ethnic minorities, people who've been marginalized by immigration status or other economic issues. 46% have food insecurity. 88% have incomes below 200% of federal poverty. 67% speak a first language other than English. We are a member clinic of the Community Health Partnership of Santa Clara County, or Santa Clara Valley, I should say. And so I'm going to sort of narrow into a little more of the services and how we deliver them. Although many of the people before me, my colleagues before me, did a great job in talking about the kinds of work that community health centers do. We are essential safety net providers, and along with counties who are providers of last resort, we all participate in the Centers for Medicaid and Medicare Quadruple Aim, which is to improve the patient experience with the goal of yielding better health outcomes, reducing costs to the healthcare system as a whole, while simultaneously improving the experience of healthcare workers, which is essential for the continuous recruitment and retention of our healthcare workforce, but also sustainability of our health centers, so that we can continue to provide access to care to the uninsured, the underinsured, and those who face barriers to receiving care, such as language, transportation, financial resources, or conditions such as homelessness, mental health disorders, and substance use. To address the health disparities, we practice population health management, which focuses on patients who are grouped by one or more diagnoses, or by their age, or by other social determinants of health, such as poverty, housing instability, food insecurity, experience of trauma, etc. Through our work, we support our patients' health and well-being so that they may possess the tools and the resources to be owners of their own health. Our goal is for people to be empowered by the work that we do with them so they can care for themselves, because as we get to see our patients maybe an hour, maybe 4 or 5 hours a year if they have chronic conditions. The rest of the time, they need to be able to operate in the world and care for themselves. And so we're here for them, and we want to give them the tools to be empowered themselves, to care for themselves. We practice population health management by transforming the way we deliver the care in order to meet patients where they are in their life and what motivates them to address their health. This is our focus. We utilize team care that can include medical assistants, community health workers, health coaches, nurses, paraprofessional panel managers, and front desk patient service representatives who, alongside our clinicians, work together to get to know a panel of patients to care for them more comprehensively. And they share a care plan, and that care plan is created for the patient, with each member of the team having a responsibility to address particular medical needs of the patient. In addition, community health centers, as Lisa recently said, we are integrating our service lines to address the whole person instead of operating in silos. The silos that in the past have fractured care and increased cost redundancy or untimely access to care that results in trips to the emergency room. The key to integration is the shared care plan through the electronic health record. And community health centers in California have made great strides in moving toward having electronic health records. In Ravenswood Family Health Network, in addition, we have combined into one department our behavioral health therapists, social services staff, medicated assisted treatment program for patients with substance use, and our healthcare for the homeless staff. The primary care provider, which can be a doctor, nurse practitioner, or physician associate, that the patient is assigned to, are also included in this care team. And they have a care team template in our electronic health record where all the services provided that patient are documented. And it aids in the communication between all members of the team and informs them on a consistent and even real-time basis of the patient status. To further support our patients, we have many community health centers, and you've already heard this, is we include alternative care modalities as part of the services we offer. I mean, one of the challenges right now is people with chronic pain, people who've been on opioids, and trying to get them into pain clinics has been challenging because there's very limited access. So some modalities that can help people with chronic pain include acupuncture, chiropractic. We also have group visits that can bring people together, such as depression support groups, patients with chronic diseases for shared educational sessions. And then the use of wearables is beginning to be used on a very small basis now, but hopefully will grow, that help people, for example, with hypertension to manage and control their blood pressure. So in addition to improve our patients' health to reduce long wait times for specialists and travel costs for our patients, we offer some specialties such as optometry, podiatry. We have x-ray, mammography, and also ultrasound at our site. We form partnerships with specialty care providers, in our case, Stanford, to offer e-consults, and adding urgent care in the evening and weekends at our sites in the community. Our dental program, besides being comprehensive, we offer virtual dental home in the classroom for children in preschools and kinder through first grade to prevent dental caries in the future, and we do it throughout San Mateo County. Through Epic Care Everywhere, Epic is our electronic health record. Our health centers are able to share patient data with hospitals and specialists who also have Epic in their EHR. And this is very important to coordinate care, reduce redundancy, and actually provides timely access to important services and important understanding of what's happening with the patient. In total, we work to fulfill the quadruple aim, and the savings through the healthcare system, we want to emphasize, should be shared with primary care, because these investments that have been made in order to keep people well in the community are essential going forward. And so it's critical to sustain this effort and evolve our care into the future, that the state continue to invest in primary care and be wary of unfunded mandates that increase cost without benefit to patient care, and also those that reduce our reimbursement. Because, as Asa was saying, it appears that we are bringing a significant amount of money through the Medi-Cal system. However, that only represents 67% of our actual cost for care. In the Bay Area, we're operating in a high cost of living environment. Sustainability depends on matching revenue to expenses to be able to retain our staff with wages and salaries that are competitive and that allow them to live in the area and continue this important safety network. So we are also key to the economic development of the communities where our clinics lie. We provide entry-level jobs in healthcare, and we are equity access employers. So we hope that through the presentations today, you can recognize the considerable value that we bring to our communities and the patients that we serve, and the efforts of equity access to comprehensive health that we provide to our patients. Thank you.
Thank you, Louise. I really appreciate your providing that additional context on the array of services and how they are integrated to provide whole person care and to meet patients' needs across the spectrum. And at this point, I'm going to turn the conversation over to Alicia. Alicia, thank you for joining us. And we know our CEO of Communicare Olay.
Yes, thank you so much. It's great to hear from all of my colleagues and focus so much on the mission, the way that we provide care and our unique place in the healthcare landscape. I'm going to shift a bit and talk more where Louisa ended her presentation, which is on margin and some of the challenges we have with the way that we're paid and how we try to stretch our limited resources. I am the CEO of Communicare Olay, which is a very newly merged entity as of just 1 month ago. This was a strategic decision in order to leverage more resources because, again, being able to support the care that we need to provide is a continued challenge. So I'm hopeful that with Olay Health and Communicare coming together and being now a 3-county system, we'll be able to have more consolidated resource. But just to give a sense of how we are paid and understanding that our mandate as community health centers is that we never turn anyone away, regardless of ability to pay. So you heard about how that works already in terms of sliding fee scales. Even if someone cannot pay the minimum of a sliding fee scale, if they don't qualify for insurance, we write that off in hardship. So we are providing a significant amount of uncompensated care every single day to ensure that everyone has access. The federal government, HRSA, our oversight body, does recognize this and provides us an annual grant. Those grants are proportionately small relative to the overall budgets that we manage. Just to give you a sense of ours, we get a little bit over $6 million that contributes to our $100 million operation of expenses. So it is helpful to have that grant, but it's not enough to cover the cost. We also have our state billing, our patient revenues, which is through the Medi-Cal program. When we look at our cost per visit relative to the revenue that we get, our patient revenues provide just about half of the total cost of care for us to provide all of the wraparound services. So that other 50% that we have as a differential, we have to supplement through grants, contracts, philanthropy, donations. So it's a constant effort to make sure that we can close the gap. And in the system that we have with the rates, we can apply to get a new rate every time that our costs go up. It's a clinic by clinic, site by site process. The state evaluates what are the total costs that are considered allowable. We sometimes have some disagreements on what we think is allowable versus what the state may think, but we come to an agreement on allowable costs, divide them by total visits, and there's a rate there. This process is quite slow and laborious. It takes about 3 years to get to a final audit of where that new rate is going to be set. So as Louisa mentioned, with mandates such as increasing the base compensation floor to $22 and then $25 per hour, without a more expeditious or efficient way to cover those costs, it definitely puts us in some jeopardy for sustainability of many of our programs. We are also experiencing a couple other challenges. One is the loss of many one-time funds that supported us through COVID. So as you heard, our patient revenues are a big part of how we continue to support the business operations. We have a very burned out workforce. Productivity and revenues have been declining in past years for a variety of reasons related to the pandemic and workforce shortages. And so the one-time funds that we received, which for us were close to $20 million, really filled a huge gap for us. Those were one-time funds, they no longer exist. And now we have the new mandates around compensation. In addition to the fact that we must advance our system to meet the needs of our communities and patients, which means overdue infrastructure upgrades such as technology, Epic implementation, having an electronic health record that can truly communicate with our healthcare partners across the continuum. All of that is critical, and it's also very, very expensive. So this is just to provide a bit of education on how difficult it can be from the back end managing and trying to support the amazing array of services. We know that our care model works. We know that the whole person approach matters. Social drivers and social determinants need to be addressed. We are so committed to doing that work and always have been. But again, it is very challenging when we do not have enough of the resources coming and continuing to come to us as quickly as is needed to pay our staff competitively and support all of the work that we do. So I just wanted to provide that in addition to, and the last point that I'll end on is that there are no other practitioners or healthcare providers who are accepting or willing to see our patients that have Medi-Cal or Denti-Cal. Again, we are the access point for everyone because we don't turn anyone away. And so we will and we have been and will continue to find ways to meet those needs. And just want all of our decision makers and legislators to understand the need for the continued resources and investments in pipeline recruitment, National Health Service Corps, scholarships, reimbursement, and rates that really truly can cover more of our costs. Thank you.
Great, thank you, Dolores. And at this, I'm sorry, thank you, Alicia. We really appreciated how you laid that out. At this point, I am going to turn the call over to Dolores, who will wrap up with examples of partnerships between community health centers and our policymaker partners.
Okay, thank you very much. Good morning, everyone. It's truly a pleasure to see you all. I want to start out by sharing with you that the fact that Jane Garcia opened this event was wonderful because that was my first job in my introduction into the world of community health centers working at La Clinica. My life changed at that moment, and here I am, still with community health centers, very proud to be there. What I'm going to focus on is a lot of the local initiatives that have an impact, not just on the clinics, the rest of the community, but a direct line to either the state or the federal government. and how we maneuvered that. It's a very fine dance, as my peers probably dance it all the time along with me, to manage working with federal, state, local policymakers, folks who have their own agenda, who are often led by money, voters, etc., as well as other organizations in our county who are very much involved in other social determinants of life, really, like incarceration, housing, etc., which all impact us. It's difficult for a consortium to really take a stand and really focus on what's really best for our community health centers. So with that, that's been my challenge for the last 13 years. But I do want to share with you some wins, if you will, of how we maneuvered it. So from a public health perspective, we were able to advocate and are currently working with one of our Board of Supervisors on a Latino health assessment. The last assessment that was done was probably 2010, 2011. Yes?
Yeah, a lot of times.
Hello? Okay. What we hope that this will bring up is some of the root causes, as opposed to just pages and pages and pages of data, because we know the data, we live the data. Our previous speaker spoke to that. So I'm hoping that this has a really root cause approach and root cause recommendation. So that's something that's going on at this moment. We're part of the leadership of that. A few years ago, we did the same thing with women's health assessment. We focused on pay equity. And some of you may be thinking, okay, so when does she get to the clinics? I'm getting there. In 2006, in partnership with the county and Blue Shield Foundation, in fact, we created the local health coverage initiative. At that point, we had over 100,000 undocumented adults. So we were able to help that out. And as someone pointed out earlier, that's going to change, again, the numbers in a good way come January 1st. But it really did help some of the families and that felt that nobody was listening to them, that nobody cared. It helped them feel honored and recognized. And we even gave them a badge to wear. I'm a member of the Primary Care Access Program at X Clinic. So it had a very positive financial access and self-esteem, or belonging to our community. That's how we created it. We did that with the County of Santa Clara, as I mentioned. Currently, we're also working on something that we started about a year ago with our health plan, Santa Clara Family Health Plan, and some other nonprofit leaders on a health equity agenda, focusing on the usual suspects, as we say, the metrics that show that our families, our population is suffering diabetes, etc., asthma for children, etc. So we partnered with San Jose State University to do all the qualitative data, and with UC Berkeley, whom we all love, and my alma mater, to do the research. We're hoping to have some recommendations to our local Board of Supervisors in about 2 or 3 months. The beauty of this partnership is that it is being funded a little bit by the health plan, by a local foundation, by State Assemblyman Ash Kalra, and then in kind by the rest of us. We happen to serve as the fiscal agent for this project. So really, really exciting to help the health plan move from just collecting data and reporting to the state to let's see what we can do about it, and to put some of the resources on the table that are not necessarily treatment resources per se. Another big win that we're proud of is it took us a while. It took us about 6 months of negotiating back and forth with the County of Santa Clara around EPIC. And at the end of the day, what happened is we were able to bring on 4 clinics. We already had 2, 4 additional clinics into the EPIC system through OCHIN, working with the county. They paid for it completely. Not only did they supply the funding, they supplied a lot of in-kind support. And we're now in the process of building that connection to specialty care and specialty mental health. A lot of it was additional funding, but mostly in kind from the county. So it has not been an easy process, and Luisa and Eileen, who are here on the screen, as well as Gardner, can attest to that. It was not easy, but we're definitely seeing some good outcomes through that. The other piece is that this was probably the most proud moment in my career so far, and certainly in all of my staffs in the clinics, when the state decided to coordinate the vaccine distribution, 2 years ago or whenever, I can't remember now when it was. And they looked at the data that was being given to them by Blue Cross or, their state folks. We saw that Santa Clara County and San Mateo were being shortchanged significantly. We are wealthy counties. We are the best example of the haves and the have-nots. The haves have, $10,000 million. The have-nots have $1, that kind of comparison. So what they did is they threw all the data together, and we did not score high enough to get the first round of vaccines. What we did, we contacted our legislators, in particularly Senator Cortese and Assemblymember Calra. Then we contacted the Board of Supervisors. Then we contacted some of our nonprofit partners and, of course, our clinics. And we staged a strike, so to speak, a big community movement, community presentation of why this was the wrong thing to do. We worked with county council and the board members, and then they worked with the Governor Newsom. We had a meeting with them via Zoom, and at the end of the day, we were moved up, to one of the top tiers to be able to start distributing the vaccine. What we had going for us is that we had already visited 40,000 homes. When I say we, I'm talking about the consortium of clinics. We had 12 or 13 community workers, something like that. In less than 9 months, they knocked on 40,000 homes in particular zip codes that we had chosen. And they brought back the data. So I was able to share with the governor's office through county council why why folks were not coming in to get the vaccine and what their income level was, et cetera, and where they lived. So that was quite a win. I think the part that was difficult always for me is sometimes having to disagree with either some of our peers or some of our other nonprofits, because I have to work on focusing on what's best for our clinics and for our clinic patients initially, and then the rest comes second, third, fourth, etc. One other thing, another example of how we worked as really, really incredible partners, we contacted community colleges. We worked with Gardner Health Center and their CEO is, I think it's on the meeting this morning, in the meeting this morning. Gardner was able to make an arrangement with one of our arts building, so arts and culture building. They just have the space, for plays, etc., a theater. So he made a connection with them. We were able to hold clinics there first to distribute testing kits and to do testing, then to do the actual vaccines. And the beauty of that is because the consortium folk we're not clinicians. So we did all the interpreting, all the translating. We were there at 4 or 5 in the morning, checking people in to get their vaccine, while Gardner and their team of nurses and nurses from the community colleges, while they did the actual inoculation. We also worked with a few of the other clinics. One of them was Ravenswood School Health Clinics, ACI. I sent our epidemiologist and her team, and she's on the screen now, go like that, Devayani. They collected all the data and started integrating it into our reports for the county. That was a really wonderful time, and it really, really, really showed how how we came together. And the reason is that we trusted each other. You know, nobody was there to take over. Nobody was there to be paid extra. People were there to do the service. We had already had a meeting with State Assemblyman Kalra and had shown him a heat map of where the COVID cases were. And of course, we chose him because that's where most of the COVID cases were, in a portion of San Jose, and then the rest in Gilroy, which is southern Santa Clara County, and then up north in pockets of Mountain View, which is generally speaking a pretty wealthy pretty wealthy community. They also had some pretty red zones with that. Another example.
Dolores?
Yes, am I almost done?
Yes, we wanted to leave just a little bit of time for some questions
Okay.
that have popped in. And thank
right.
you for these great examples.
May I mention one last thing?
Yes.
Okay, couple of things. We've been very active in the redistricting work that the county's been doing. We were on the governing committee of the redistricting to really allow for folks of color to, be able to be better represented. So that was quite a difficult task for me, because there were some people that were not very happy, but I knew that we were doing the right thing, and the board knew. We are also part of the health plans governing board. So we have clinics, one clinic right now represented, plus the consortium, so that there it's very easy to be able to speak up on behalf of the clinics. So I thank you for giving me the extra time. Thank you.
Yes, absolutely. Thank you, Dolores, for wrapping on those strong examples of community partnerships. And I really want to thank Jane, Asa, Louisa, Alicia, and Dolores for lifting up the complexity and the diversity of how you serve your communities, because it goes so far beyond delivering healthcare services. You all have given amazing examples of service to your community through advocacy, representation, amplifying voices, addressing social drivers of health, et cetera. And at this point, I did want to turn the call over to two more of my colleagues, Dina Lon from Vice President of Policy and External Affairs from the San Francisco Community Clinic, and Catherine Ming Hyde, Director of Policy and External Relations at Community Health Partnership. They have been monitoring the chat, and so we'll wrap us up with a few comments and Q&A. Thank you, Dina and Kathy.
Hey, thanks to all of you for being on. We don't have as much time as I would like for questions, but I will say one question in the chat was, are community clinics involved in medically assisted treatment for substance abuse disorder and harm reduction? And we are very involved. I know there's a bunch of my colleagues on here who posted in. I know in San Francisco, Health Right 360 is a real leader, as well as BART Community Healthcare, Ravenswood, Communicare, Olay. I don't have time to even list everyone, but that's a really good example, I think, of how community health centers rise to meet the needs. So as everybody has emphasized, we are not just about providing healthcare in the traditional sense. We're about addressing all the needs of the of our community. And I just also got a question about workforce. There's a million ways that we all work to try to increase the healthcare workforce. It's tough because we don't offer as high salaries, although we do offer a great mission driven and a very warm culture. And that's why a lot of people have chosen to work at community health centers. At San Francisco, for example, we have a very innovative CHW program, which is both a workforce development program and a program to help serve the social determinants of health. So we're growing a homegrown community health workforce, and our CHWs get certification through City College of San Francisco, and then we are doing a project to look at where they make the most difference. A bunch of us have AmeriCorps, which is a program to get recent high school or college grads into the community health center world. We're an AHC center to train healthcare professionals, and we do a lot of other things. I have a feeling we only have one more minute, so I will just say that I think we were hoping to give an introduction to why community health centers are different. So I hope what you will take away from this is that as healthcare in general becomes more business focused, more focused on profit, more focused on in and out, quick and dirty kind of solutions, we are focused on the whole person. We are providing links to food, transportation, housing. We're providing integrated behavioral health care. We're providing medically assisted treatment for substance abuse disorder. And we're working in our communities to grow a diverse workforce. All of our work is focused and dictated by the needs of the community. And we want to draw a contrast between that and a way a lot of our healthcare system works. So thank you all for coming on. We had over 120 people. We're really excited about that. We will have further discussions on topics that go into more detail about things like workforce and how we're funded. But I just wanted to mention that we really thank all of our partners and the elected officials and staff who have joined us today, and know that we can't do this without you. And we're really looking forward to working together to improve the health of our communities. Thank you.
Thank you, everyone.